Hello and welcome everybody to our first HTLL webinar for 2021 on vaccine campaigns. Before we start our webinar, I just want to remind you, you will have noticed a message when you joined today's meeting that this call is being recorded. We will make the recording available to you after the meeting. If you have any questions that you would like us to ask our guest speakers at the end of this webinar, please put those questions into the chat box in the Zoom function. And if you could also type your name and job title into the chat box, that gives us a nice idea of the participants that we have in our webinar. So today's webinar is on lessons learnt from ADRA's long-standing polio vaccination campaigns, which have been running for a number of years in both India and Kenya. And we have three guest speakers. Our first guest speaker is Josue Oriana Guevara, and he was born in Bolivia. He's a physician from the University of Mayo in Bolivia. And he also holds a Master of Public Health from the Loma Linda University. Josue has developed a special interest in community health and international health and has joined the Adventist Development Relief Agency in 2002, holding various positions within the global network. He's acquired extensive experience in international health and development. Most recently, he has spent 4 years as ADRA Country Director in Mongolia and 3 years as Country Director in Nepal. In 2018, Dr. Oriana took the role of Director for Health, Nutrition and WASH at ADRA International based in the States. As part of his professional career, he has been involved in emergency response in the health sector as well as other sectors, working on the front line and at a managerial level in several countries. He has also been engaged in interventions to promote healthy behaviours and best practices in maternal and child health, reproductive health, nutrition, hygiene and non-communicable diseases, including tobacco control and lifestyle programming. Our second presenter is going to be Mohamed Ahmed Adan, who is from ADRA Kenya, and he works on the CGPP GHS project as a project manager. Mohamed has 10 years experience in community engagement, and he is a registered community health nurse in Kenya, and he is currently doing a Bachelor of Nursing. Mohamed has experience in reproductive maternal child health, community nutrition and immunization, community-based surveillance structure. He has had 4 years of experience with Save the Children prior to his 6 years experience with ADRA Kenya. We also have Shilpi Das from ADRA India presenting today. Shilpi is ADRA India's Program Manager in Health and brings a wealth of experience from the health sector. Shilpi has built on her interest in infectious diseases to bridge her Masters in Veterinary Public Health with a postgraduate diploma in the management of reproductive and child health programs. Having worked at the National Centre of Disease Control, Shilpi has implemented several national scale projects. She is associated with ADRA India since 2017 and has been spearheading various health projects with special reference to the core group polio project, the tuberculosis care and control adolescent health projects. I want to welcome each of our three guest speakers to our webinar today, and we are going to hear now from Dr. Oriana. Thank you, Josue.
Thank you, Victoria. And good morning, good afternoon, and good evening, everyone. It's nice to see many of the names of our friends here and coming together again. So let me quickly start with a brief overview about vaccines and vaccinations. because I would like the focus to be on the experiences in Kenya and India later on. But let me just set the ground ready for what is going to be presented by our colleagues from those country offices.
Oh, sorry, can I stop you really quick? Are you seeing the correct slide on your screen? Or are you seeing the presenter view?
No, I think it's the correct slide.
Okay, I apologize, sorry, go ahead.
Thank you. No, thank you for checking that. Okay, so for some of you, this might sound like too basic, but I just want to make sure that we all have a very basic understanding, at least the minimum, when it comes to vaccines and how it works in terms of our immunity as well. Let's go to the next slide. So some general considerations about our immunity and how the types of immunity and how it reacts. So we have two main types of immunity: innate immunity, which is also called general immunity, and adaptive immunity. So innate immunity is the immunity that we are always developing and we have all the time, even before we were exposed to the antigen or to the virus, to the germ or whatever agent it is. So it protects us. It gives us general protection against harmful agents, and this is the immunity that we also strengthen when we, depending on our lifestyle, on the choices that we make with our lifestyle. It is very important to make it very clear here that vaccines are not included here in this type of immunity. So if we say that by having a very healthy lifestyle, we are already being immunized or vaccinated against certain disease, that is actually not true. That is not correct. But I did want to mention this type of immunity because it is very important. So we shouldn't also undermine this to strengthen our immune system in general, and to have a good lifestyle as good as possible, so we can support the other type of immunity, because these two types of immunity work together. Then we have the adaptive immunity, which could be active or passive. The passive immunity is either comes from your mother. It's transmitted from your mother. Antibodies that pass from the blood of the mother to the blood of the fetus when the baby is still in the mother's womb. Or the other way is what it says here, artificial, which means the convalescent plasma that is taken from somebody else who has already been exposed to the disease, and then that plasma is given to a new person. Or it can also, those antibodies can also be developed artificially, I mean in laboratory, and then those antibodies are used for a patient who is already sick. Why is it called passive? Because in this case, your body is not producing those antibodies. Those antibodies were put into you, and then they have a limited life. So then at some point in time, those antibodies will fade away from your blood. On the other hand, the active immunity, which is going to be the focus today, could either be natural or vaccination. Natural means when you have been exposed to the agent, in this case to the virus, to the polio virus or to the coronavirus, the novel coronavirus. You have been exposed, either you were asymptomatic, you had a mild disease or a more serious disease, then your body develops antibodies against that virus, that agent. Or the other way is through vaccination, which is going to be the specific topic for today. So you don't get the disease, but you, through the vaccine, you develop those specific antibodies Let's go to the next slide. So understanding vaccines. This is very basic again, but just for us to remind ourselves on how it works. So we have here, and I forgot to ask here if I can draw on the screen. Let me see if I can do that. No, I don't think I can do that. Anyway, I think you can see my pointer, right? My mouse. So we have here on green the disease-causing organism, the virus, the bacteria, parasite, whatever. That is the agent that causes the disease. Now, for the vaccine, we need just this little piece that you see here. We don't. This is the kind of identity marker for the agent. I mean, for the organism, the virus in this case. It's just their identity. So, there are several ways to use this identity marker. In some cases, in some of the vaccines that are available, I'm not talking about the COVID vaccine here, but vaccines in general. In some of the vaccines, the entire agent has been inactivated, like we will see in the case of polio, has been either inactivated or it's not dangerous anymore, or it has been killed, but the agent is still there, and it still carries its identity marker, which is this what they call the spike protein. So this is what in different, even using genetical engineering, this identity marker is developed, and then it is either, as I said, it's either used inactivated or killed virus, or a weakened virus which has been weakened, or sometimes it's developed through other means, or sometimes like I think there are 2 or 3 of the current COVID vaccines right now, where this spike protein has been inserted into another virus, a kind of vectorial. They are using a vectorial virus, which is an adenovirus. So, which is harmless. It doesn't cause any harm to you, but they inserted this spike protein there in that virus. So we'll talk a little bit more about that later. Let's go to the next slide. So here we see again the identity marker, which is the antigen. Then when this antigen comes into our blood, our body develops immunity, which is the antibody, and we see here the antibody. So the antibody is another protein, because both are proteins. The antibody is developed specifically to recognize this identity marker, the antigen. So in this case, it's developed, as we said, either in a natural way. That means when the actual virus came into our blood, or it is developed through vaccination. That means it was through the vaccine, and our body is trained to recognize this identity marker. So once the actual virus comes into our blood, then our body is ready to identify it and to destroy it, to kill the virus. Let's go to the next slide. So, but now let's talk about the process of developing vaccines, and we'll watch here a short video.
Developing a vaccine is a long road full of checkpoints. Different phases of testing are designed to make sure it is both effective and safe. But with the whole world struggling to contain a pandemic and unprecedented amounts of scientific work taking place, the road to finding the COVID-19 vaccine looks more like this. But first, let's take a look at the usual path. During preclinical trials, the vaccine is tested on animals to determine whether they develop antibodies to the disease-causing germ. If these trials are successful, the candidate vaccine moves on to phase 1 trials in humans, during which the vaccine is given to a small number of healthy adults to assess its safety in humans. The results of every phase are reviewed by independent clinical experts who assess the research team's findings. Sometimes they'll pause the trials to check the results, always making sure the candidate vaccine is safe. The next phase involves testing a larger group of people to find out the appropriate dose, whether it stimulates an immune response, and of course, to assess its safety. Once the results have been checked by the independent expert observers, the candidate vaccine is evaluated among thousands more volunteers. This phase determines whether it is effective against disease. If the answer is yes, the vaccine is independently assessed by regulators for effectiveness, safety, and manufacturing quality. It is also assessed by independent policymakers who determine the best way to use the vaccine. If the assessment meets the regulatory standards, the product can be authorized for use, and the vaccine is then ready for licensing and registration. Once that happens, the approved vaccine can be used in the population. But because of the urgent need for a COVID-19 vaccine, some of the phases can run in parallel, and the research team can submit a request for temporary authorization from national regulatory authorities and an emergency use listing from WHO. This authorization and WHO emergency listing are only given if the vaccine meets strict safety and effectiveness criteria. But the road doesn't stop there. Once the vaccine is in use, it continues to be monitored by health authorities for safety and for effectiveness to ensure the vaccine maintains the highest standards. The race is on to find vaccines for COVID-19, which is why some phases are happening at the same time. But no one is cutting corners. Everyone is subject to the same checks and independent monitoring. So although we'll get the COVID-19 vaccines faster, they'll be as safe as other approved vaccines.
Thank you for showing the video. So just one comment about the video. You might still be wondering, but why has it taken too long to develop other vaccines and this one has been developed? I mean, the COVID vaccine has been developed very quickly. And the short answer is it is because there has been a large amount of resources, and I'm talking about money, that has been put into it internationally, from the UN system, developed countries, vaccine developers, and others, and private investors as well. So a lot of money has been put into it, so to make the process faster. So available vaccines. This is not a complete list, but it is what the WHO is currently listing. There are a few other vaccines that are also available that are not yet listed here. You see available vaccines, and you see the ones that are in the pipeline, the ones that are still under development. Let's go to the next slide. So our subject for today, the polio vaccines. There are two main. There are a few others as well that are less known, but these are the main known vaccines, polio vaccines. So as we know, polio is a viral disease, and it produces paralysis. It mostly affects children, and that is one of the main differences with COVID. When we talk about polio, we are mainly talking about vaccinating children under 18, or depending on the country, but most countries have said under 18, sometimes under 5, or even younger children, but usually they go up to 18 years of age. Adults can also be vaccinated, but it's mostly the ones who are really more at risk are children. And as we all know, COVID affects mostly adults, especially elderly people, and those who are immunocompromised or who have other concomitant diseases. So that is one of the differences. Now, as you can see here, a comparison of the two polio vaccines. The IPV, which is injected, it is given through an injection, and OPV, which is given orally through drops in the mouth of the child. So the IPV, the injection is a killed virus, while the other one is a live attenuated virus. This is what I was talking about earlier. The two different types. These are two different types of developing a vaccine. But this live attenuated virus is not harmful anyway. So it is not it is not capable to cause polio disease. Now, I already talked about the way it is administered. The injection induces circulating antibody, no local immunity. When it says local immunity, it refers to intestinal immunity. So it only develops antibodies circulating in the blood, not in the surface of our intestines. While the oral vaccine, the OPV, develops both humoral, which is in the blood, and also intestinal immunity. Which is here somehow we see another comparison to COVID, to the coronavirus, novel coronavirus. The thing is like COVID, and with a slight difference, both viruses enter through these surfaces. In the case of the polio virus, through our intestines, and in the case of the novel coronavirus, through our respiratory system. So, and on those two surfaces are the main point of contact where the virus enters our circulation, our blood. So, in the case of the polio virus, if we have immunity on the surface, that means local immunity, intestinal immunity, then the virus will not even be able to enter into our blood, and it also has other benefits for the person and for the epidemiology of the disease. Then we also see that in both types of vaccine prevent paralysis, but the injection does not prevent reinfection, but while polio viruses, while the oral vaccine prevents reinfection because it develops intestinal immunity, and that's exactly what I was talking about earlier. It prevents reinfection because, and we have to make a difference here between infection and disease. When it says here that the injectable vaccine does not prevent reinfection, it doesn't mean the person can get sick with polio. It doesn't mean the person can get paralysis, because the vaccine is effective to prevent the disease, but the person can still be reinfected because the immunity is only in the blood, circulating in the blood, and that is also applicable to COVID. Right now, there is no vaccine that develops local immunity. That means on the surface of our respiratory system. There is no COVID vaccine that develops that local immunity. That's why we say that with the COVID vaccine, the person what we prevent is for the person to get sick, and especially serious illness. But the vaccine does not prevent. At least right now, there is no clear evidence that the vaccine protects the person from being infected again. Since there is no surface immunity, no local immunity against COVID, then the person could technically be infected again, although the person will not have the disease. And that has a lot of implications when it comes to transmission, because even if the person doesn't get serious symptoms, the person could still be a carrier and transmit the virus to others who are near to them. So there are still many things we need to learn about the COVID vaccine. But in terms of the polio vaccine, as you see here, one of them is effective with intestinal immunity, which means, as you see in the next part, it is useful in controlling epidemics because it prevents reinfection. So that means the person cannot be a vector anymore to transmit it to others. The injection is more expensive because yeah, there are several factors why it is more expensive, and but it does not require stringent conditions during storage and transportation. But the oral vaccine, once it is stabilized, it makes it easier to transport and for the cold chain, for the logistics. So this is just a brief comparison between the two polio vaccines. Let us go to the next slide. So here I just want to talk very briefly about the COVID vaccine, and just put a chart here from the BBC. Just three of the four actually of the main vaccines that are being developed. There are right now around 25 different projects that have been somehow interacting or have been monitored by the World Health Organization. But out of those, only 3 of them have been included in the emergency use listing. That means they have been given emergency authorization for to be used by the WHO. And those 3 are the Pfizer vaccine, the first one that was approved by a regulatory body, and the 2 vaccines that have been developed by AstraZeneca and Oxford University. Let me explain also here that AstraZeneca has developed so far three vaccines. One of them is what is called non-COVAX, which is not for the. It has not been taken through the UN system, but it has still been analyzed and it is still safe, and it has already been approved by regulatory bodies in the countries that are using it. And the other 2 that were recently approved, just the day before yesterday, on Monday, the WHO officially announced that the other 2 AstraZeneca vaccines were also approved for emergency use. And those are the vaccines that are being exported to most countries and are being used. And those vaccines, although the brand belongs to AstraZeneca and the University of Oxford, but those vaccines are developed, one in India and the other one in South Korea, and are cheaper. Are the requirements for the cold chain are easier to comply. So yeah, that brings somehow good news. It will be easier, and most developing countries are actually using one of those two vaccines, although the other ones as well. Now, the other vaccines, including Moderna, the one developed by Moderna, and the Russian vaccine, Sputnik 5, and the various Chinese vaccines, are still under analysis by the WHO committee, and have not yet achieved the certification they need in the emergency use listing. Now, what does it mean to be listed in this EUL list? This is an international body that is meant to help those countries that do not have their own regulatory body, or if they have one, they do not have the necessary capacity to do all the necessary analysis and approvals, analysis mostly, so they can then approve in a safe manner, complying with the standards, a vaccine. Any country can still take any of these vaccines, and if they have their own capacity with their own regulatory bodies, like the FDA here in the US, they do the analysis, they take the data, and they do whatever they need to do, even inspection the facilities of the manufacturer as well sometimes, to make sure the vaccine is safe. So, but for many developing countries, that is not the case. They don't have that capacity. So the WHO is taking that role instead of them. So then they can quickly approve that vaccine because it has been kind of vetted quickly by the WHO. So then those countries can start using that vaccine. That is what means this emergency use listing. Let us go to the next slide. So a lot has been said about herd immunity, and when we talk about herd immunity of any type of disease, we are talking about achieving that level of immunity, so the virus or the pathogen cannot continue to spread, and it fades away, it dies out, because it doesn't find vectors to be transmitted. It is technically not possible to achieve 100% immunity. That means to immunize or to develop immunity for the 100% of the population, because there are always people who, for any reasons, are not able to develop immunity or cannot be vaccinated. Like in many cases, people who are immunocompromised, whose immunity is weak. Either it is induced with pharmaceuticals, or because it is related to another disease like HIV or others. So some of those individuals cannot be vaccinated with some of the vaccines. And sometimes some population groups, sometimes pregnant women, sometimes children, sometimes elderly adults, or others are not able to receive the vaccine. So, but if the rest of the population is vaccinated or develops immunity, then we achieve herd immunity, and then the virus will die out, will just fade away, and transmission will be stopped. And then we will be reaching the point of eradicating that disease. Now, you may be wondering what is the percentage of the population that has to be immune in order to achieve herd immunity. And unfortunately, there is no specific figure. Earlier in the pandemic, we were talking about 60 to 70% of the population needs to develop immunity. But now it's clear, and that there have been cases, there have been countries or smaller settings, like in the entire city, for example, where even more than 60% of the population were infected, mostly through being exposed, becoming sick with COVID. And in spite of that, the virus is still wreaking havoc in those places. So it is definitely higher than that, maybe 70 to 90%, but don't quote me on that, because scientists still don't know what is the percentage of immunization that we have to achieve in order to achieve herd immunity. So this is just to somehow to explain how it works in epidemiology, and to transition now, after we have this background, to transition into the experiences that we will see that are coming from our colleagues in India and Kenya. This is my brief introduction, and thank you for listening.
Thank you, Josue, for the presentation and giving the platform about the vaccination. Good morning, good afternoon, and evening. I am Dr. Shilpi working with ADRA India as a Program Manager Health. Today, I will try to share ADRA India's experience and lesson learned from the polio vaccination campaign and its application on the present situation on COVID-19 vaccination rollout. So before I move on to the lesson learned, a very brief about the core group project. Core group is supported by USAID and has contributed to improvement in routine immunization program and polio campaign. The project has been focused on high-risk areas and hard-to-reach population. And in India, CGPP has been working in Uttar Pradesh, which is one of the largest populated state in India. The 3 districts of implementation in India are Baghpat, Rampur, and Bareilly. These are the 3 districts of Uttar Pradesh. Next slide, please. So while many factors contributed to the success of elimination of polio from India, effective partnership and coordination mechanism at multiple levels have been a very important element. The CGPP structure in India includes a secretariat, international implementing NGOs. ADRA is one of the international implementing NGOs in this part, and several other local NGOs. The sub-regional coordinators, or the SRC, leads the team from the field and is further supported by the block mobilization coordinator, also known as the BMC, and the community mobilization coordinator, CMC, who are in direct contact with the community. Next slide, please. So the project has developed innovative strategies to detect cases using community-based surveillance, strategic training approaches, and establish a cadre of community mobilizers to track missed children and deliver behavior change education and improve the immunization coverage. And many of these approaches actually has now been replicated by the government and international agencies to tackle many public health priorities. The slide presents here the important pillars or lessons of the polio campaign and which are further replicated for COVID-19 rollout. And each lessons or pillar will be covered in the next slide. So there are 5 main pillars which we'll be selecting: communication strategy, evidence-based planning, community trust and human resource, leveraging partnership and supportive supervision. Next slide, please. So the first lesson is, of course, the communication strategy, which we'll be discussing a bit. Communication strategy has always been the backbone of the project. Initially, many doors were closed, rumors were spread, and hundreds of families said no to polio vaccination. This was like years, almost 10 years back. However, with time and further analysis of the gaps, it was realized that the initial communication was more of instructive and one-way communication rather than a two-way communication. So the project did some rethinking and reviewing, and a communication strategy was properly planned. The mobilizers' technical knowledge was strengthened. The mobilizers were trained to listen to the community and able to identify the root cause of refusal. The SBCC tool of gather approach was introduced, which included greeting the family or the mother, asking of their well-being and trying to assess, together talking and listening to them, help in identifying the problem and explaining the mother about the problem, and assuring of a revisit and final recommendation. Next slide, please. So this slide particularly depicts the simple communication tools or the fun-filled tools which are introduced in the polio project. These are basically indigenous games through which the mothers are explained about the benefits of vaccination and hygiene. Next slide, please. So when the COVID-19 pandemic started, the polio team were mobilized or activated, and telephonic and online training initiated for COVID-19 communication strategy. The team supported the community at the pandemic's peak time and built in the trust of the community. The COVID-19 communication strategy objective was majorly to address 3 objectives. Number 1 was vaccine hesitancy. People were hesitant of taking vaccine. They were a group of section of people who were hesitant to take vaccination. The second was vaccine eagerness. They were also a group of people who were eager to take vaccination. And the third is, of course, providing correct vaccine information. So these three were the prime objective for the COVID-19 communication strategy. And this was achieved through advocacy with stakeholders, capacity building of health workers, media engagement, social mobilization, and community engagement. And last, but one of the most important, was handling of the AEFI crisis, like adverse effect crisis communication. And this was like the influencers were oriented on how to handle AEFI crisis. If there was any crisis or any rumors which was spread, then the influencers were the one who used to communicate, and the communication strategy was overall done through these channels. Next slide, please. So one of the best practice of polio programming was evidence-based planning or microplanning. And that included an estimate of total resource that is required and is made several months in advance. So supplies can be ordered in advance. So based on the supplies, the logistics and the operational planning is undertaken. And that includes availability and deployment of cold chain equipments, cold boxes, plan for transport of vaccines, team movement plan, operation maps, and many others. So supportive supervision helped in taking corrective measures on spot and report finding at feedback meetings. The reporting tools are simple field-based tools that was used to collect real-time data on the microplanning implementation. This particular picture shows a group of mobilizer with their registers and maps, which they were planning for as a microplanning before the polio round. Next slide, please, Kerry. So the microplanning of the polio campaign was replicated for preparedness of COVID-19 vaccination rollout too. Since the polio project was already there, the beneficiary listing and estimate was not very challenging. Daily and weekly planning were undertaken for preparedness activities and review of progresses. The microplanning had detailed planning on training, supervision, and monitoring plans. So for rollout of the COVID-19 vaccination, the cold chain supply capacity were rechecked and enhanced. Prior to the real vaccination day, a dry run was undertaken by the government to test and check the preparedness for the vaccination day. And real-time data were taken through an app known as the CoWIN app, and the vaccinated people were registered through this particular app. So this particular picture shows the ADRA's team participation in the district task force, which was a regular routine during the COVID-19 vaccination rollout for planning and microplanning the whole rollout. Next slide, please. So this slide basically talks about the community trust, which is of course the backbone of the polio project. And it is an important pillar of the project, and the influencers played an important role during the polio campaign. One-to-one and group meetings were organized in several areas for generating awareness and building trust. Next slide, please. So as mentioned in my previous slides, the community trust was built up when the pandemic was at the peak. The mobilizers supported the community and migrant population when there was extreme fear about COVID in the community. This was when COVID just started in March in India, the lockdown started. And there was extreme fear among the community, and there was rumors and many problems the migrant were facing. So at that time, these mobilizers were activated. The community were reached out through phones, WhatsApp group, and counseling was provided by the mobilizer. Thus they established the confidence of the community. The influencers who supported the polio project were looped in as a group and renamed as a community action group, or the CAG group. These groups were trained to address vaccine hesitancy, eagerness, and to have appropriate COVID behavior like washing hands and wearing masks. So this picture will show a CAG meeting which has been undertaken by one of the block mobilizer during after the lockdown was over, and physical meeting was there. But with all the protocol, COVID-19 protocol, these small group meeting were undertaken. Influencers group meeting were undertaken by our mobilizers. Next slide, please. So partnership was the key behind the success of the vaccination program. The various partners involved in the rollout of the vaccination were the government, who was steering the vaccination drive with technical support from WHO, communication strategy drafted by UNICEF, Rotary Loop for social mobilization, UNDP for technical support on CoWIN app, and the community who were always there to support as influencers or supportive supervision. Next slide, please. Monitoring and reporting were undertaken during pre, post, and on-the-day vaccination by the mobilizers. Pre-vaccination tools include preparedness assessment, logistic and distribution plan, micro-planning for AEF preparedness, and community mobilization. On the day of vaccination, supportive supervision was taken to visit a designated site of vaccination and given feedback for corrective measures. The post-vaccination mainly included compilation of reporting formats and documentation of best practices and the lesson learned. Next slide, please. So on the day of vaccination and also during the dry run, appropriate COVID-19 behavior was undertaken at the session sites. The immunization site was sterilized and units of vaccination and verifier were designated well. So this you can see in the pictures. The appropriate COVID behavior they were having during the vaccination day. Next slide, please. So on 16 January 2021, India rolled out the largest vaccination drive in the world. And this particular picture shows a selfie booth where the people who got vaccinated, he or she would come over, take a selfie or take a picture and would share it on the social media to have a community trust. Next slide, please. So I think this is my last slide. And until last week, India already had more than 7 million people vaccinated. And by today, I think it will be more than 11 million people. The quick planning and turnout of the successful vaccination program was all because India's experience in rollout of large-scale vaccination drive and the lesson learned from polio and the routine immunization has been instrumental in the success of COVID-19 vaccination drive. Thank you, everyone. Over to you, Victoria.
Thank you very much, Shilpi. That was really, really informative, and I liked the different range of methods that the core group polio project used to communicate and deal with various maybe opportunities for misinformation relating to that vaccine. And I just would like to hear you share a little bit more about how you would recommend to combat misinformation about vaccines. I mean, you talked about various communications and social mobilizations and trust being the backbone of the polio project. So there was a range of different ways that misinformation could be combated with the polio project. How do you think that that would relate to, you know, COVID vaccinations?
Right, Victoria. Misinformation was always part of the polio vaccination from the beginning, and it was dealt very well with various IEC materials, which were very simple to be understood by the community. IEC materials and various messages on the social media. But one of the most important contributor for this misinformation, for mitigating this misinformation, were the influencers. Once the influencers are trained in the community and they are given the right messages to be shared to the community listens to these influencers. So the influencers were one of the prime person or focal point who mitigated many misinformations.
Good to see. And I guess the selfie booth with the COVID vaccination is a form of an influencer because they're sharing their image on social media. Were the polio vaccination campaigns paired with messaging around actions or factors to help prevent polio?
Yes, so the polio, it was not only about taking 2 drops of polio vaccination, but the messages were also around how hygiene should be maintained, how behavior changes should be done, so that the spread of the vaccine is, the spread of the disease is not there. So there were many programs or small activities which were dedicated to the school, for the school children. Like it is in India, we call it as Mastiki Kaksha, like fun in the classroom. And small booklets were shared with the children, and these messages were shared with the children, so that this was further communicated to the parents. So yes, of course, it was not only about 2 drops of the polio, but it was also around messaging of hygiene and cleanliness to stop the polio transmission in the community.
Okay, very good. This is probably going to be a bit of an unusual question for you, Shilpi. I hope you don't mind me asking it, but what do you see as a valid reason for not getting a vaccine? Not necessarily just for COVID or maybe polio, but for anything.
From my experience, we found that the most valid reason for not getting any vaccine is the lack of correct knowledge. They didn't have, and the misinformation. Like rumors just spread like fire, and because of this, there were many misinformations which were spread, and many people didn't have the proper knowledge to understand, and they just knew that the information which was shared in the social media was correct. So I think these two were the prime thing. Further, the fear of AEFI, or the adverse effect for immunization, were also there, one of the things for not getting vaccination, because after polio, if there is slight fever, then usually there is the fear among, like, why my child is healthy, why should I go for vaccination, and the fever will happen. So I think these 2 or 3 points are really important for not valid reason for not getting vaccination.
Thank you very much, Shilpi. We're now going to have Mohamed speak to us about his experiences also with the polio project in Kenya. Thanks, Mohamed, and welcome.
Thank you, Victoria.
Thank you, Victoria. Thank you all. Good afternoon, good morning, everyone. So my name is Mohamed Ahmed Adan from ADRA Kenya, Polio Group Project Manager. So Co-Group Polio Project is implemented in Kenya in almost 7 counties, 7 districts. So ADRA is one of the implementing partners for Polio Group. So we are implementing it in Mandera County of northeastern region of Kenya. So as you can see in the map of the map, so that the tip of the corner is where Mandera is, which is bordered by Somalia, Ethiopia. So there is also the arrow indicates the porous border where movement is in and out of the county where the project is being implemented. Next slide, please. So the project objectives were built on 6 key objectives. One was to build partnership in polio and zoonotic disease surveillance and response, support efforts to strengthen national and regional vaccination system to achieve polio eradication and zoonotic diseases, support involvement in national and regional planning and implementation of supplementary polio immunization and zoonotic disease outbreak response, support effort to strengthen acute flaccid paralysis and zoonotic case detection and reporting, and support timely documentation and use of information to continuously improve the quality of polio eradication and zoonotic disease surveillance and response, and support participation in joint cross-border initiative for polio eradication and global health security activities. Next slide, please. So, activities that normally done prior to polio campaigns include vaccines, arrangement, IEC materials, which are, and monitoring tools, which are distributed from one central vaccine store to regional depots. So all the vaccines are just stored at one regional. So all the districts normally collect their vaccines, IEC material, all the requirements are just collected from one site. Counties, sub-counties pick their supplies from the regional stores, and then from the county now, sub-counties also pick their stores, their supplies. A plan of distribution of vaccines and other logistics were made in place 1 week before the campaign normally. So focal person to monitor vaccine stocks at the mini depots were normally assigned. High-risk populations, nomads, refugees were mapped. Advocacy and social mobilization done 1 week prior to the campaign. Next slide, please. So during that polio campaign, our role, some of our roles include: 1, support community-based surveillance system through working with Department of Health and Veterinary Services, strengthen joint cross-border coordination meeting with partners and departments of all sides of Kenya, Ethiopia, and Somalia. So support hard-to-reach population with special extra teams, which are dedicated along the border, the pastoralists, the nomads, all those things. Support supervision, team monitoring, social mobilization, advocacy, and also investigation. During that polio campaigns, we normally, any case of suspected polio, supported AFP cases were normally investigated and supported, so we support during that. And then also we organize and attend daily review meetings to share the feedbacks from the teams. Next slide, please. Lesson learned during the polio campaigns. One of the lessons were robust cross-border collaboration along the Kenya-Somali borders improves quality of polio immunization activities, as well as acute flaccid paralysis, case detection and reporting. So when we are collaborating along with the partners, all the Ministry of Health from Kenya, Ministry of Health from Somalia, we normally do robust cross-border collaboration. And also we have during that campaign, we also have a WhatsApp application for ease of communication and feedback, sharing of best practices also. So most of the time during the polio campaign, we just form a polio campaign, and then all the vaccinators, mobilizers, team supervisors are in. So anytime you are in a good network, you just chat anything that you find out during the day, you just capture. Updating of microplans prior to polio campaigns, also including mapping of border communities, pastoralists, and hard-to-reach population, and also has high-risk areas population. So hard-to-reach populations, these are the nomads, and also those villages along the border, because due to insecurity areas, those areas are also mapped, and a special team dedicated for those are normally assigned. So the strategy also that the polio campaigns use, they use house-to-house strategy on vaccine administration, even though for COVID-19, it will not be, because it will not be possible, because it's an injectable and polio is an oral. So, but the strategy normally works very well for polio campaign. Next slide, please. So is continuation. So community-based surveillance activities are key normally during polio campaigns, and especially in security compromised and nomadic pastoralist communities. So during that polio campaigns, we normally encourage a lot of community-based surveillance system. Single antigen campaign with polio do not necessarily adequately address the needs of nomadic population. So what we do, sometimes we just, instead of just carrying polio campaign, then you just had some dewormers, multivitamins, and then also some antibiotics, so that in case you came across a sick child, you just need to treat also in the way. So we normally we combine together need for recruitment of person at county. Normally a person is dedicated at the county, also at the county, to monitor vaccine utilization. So sometimes, so there's also a dedicated person at the store, whereby is dedicated for vaccine utilization and counting of those vials, those and returning during the after the polio campaigns. Next slide, please. So need to have continued engagement beyond campaigns with vaccine resistance groups, such as hard-to-reach group, religious groups, nomadic. So during in case of there's refusals, so we don't just encourage people just during the polio campaign that there's a refusal. No, we normally have to engage community volunteers, community mobilizers, even elders, to go beyond even the polio campaign, to continue engaging on those who have vaccine hesitancy groups. Specific strategies normally to mobilize nomadic population, including movement tracking and using nomadic elders as mobilizers. So those normally the community, the nomadic pastoralists, those who normally not as such the refusal, but they sometimes they don't value, because today, tomorrow might be a vaccination day for them, and then they might shift. So instead of now bringing another person volunteer from other villages, so in this settlement now we choose an elder so that he calls back that the polio team that they have shifted from this side to this side. So please tomorrow come to that direction. So we normally use that use of locally recruited and trained social mobilizers, community volunteers to support the pre-campaign mobilization, as well as having these mobilizers. So during instead of having mobilization, social mobilizers differently and then vaccinators differently, we use now the same mobilizers now to have as a volunteers during the campaign also. So this means, so this person is double engaged. So he has trust, and he has the community trust, and also he has the trust from the other departments. So we normally engaging like that. So next slide, please. So tracking and tracing of nomadic settlements, building a strong linkage with the members. So we normally have that engagement prior to campaigns also, and also after the campaigns, we normally have that linkage, engaging mobilizers from among the nomads, identify the family members, relatives who remain behind in the rural areas or urban centers, permanent settlement, and engage him or her as a mobilizer to give information on movements and location of settlement. So we normally assign a volunteer just the same as a local person. So in case of this movement, some people shift from that settlement to another settlement. Others normally were left behind. So this person now keeps on updating the team on the movement of those nomads. And the use of ODK, Open Data Kit platform, in real-time monitoring and providing feedback during polio campaigns contributed to improving quality of polio campaigns. So this system of online, whereby so you monitor even the team, the vaccinators, the team supervisors, they move. There's the district supervisors, there's sub-district supervisors, and team supervisors. All these people use that platform to monitor the movement of the team. So that also works very well during the polio campaigns. Next slide, please. Thank you.
Thank you, Mohamed. That was really informative, and I can imagine having quite a wide geographical spread across Kenya, which you have for the implementation of the project, would be quite challenging. And I wondered, you mentioned that there were counties that picked up their supplies from regional stores. And so I was just wondering, how were you able to store the polio vaccine during the transportation and delivery process to those remote communities? Did you have troubles keeping the vaccines cold? And what recommendations would you have for overcoming the cold chain requirements for the current COVID-19 vaccine?
In fact, the vaccines are normally collected from Nairobi, which is almost 1,000 kilometers away on roads. So it is transported to the county or the district 1 week prior. So after that, it is now taken back again to sub-district. From there, it is now distributed to the facilities through cold chain. So throughout, there is also monitoring of cold chain, strict monitoring, whereby the vaccines, so far we have never heard of vaccine VVM going out of many, but there is strict adherence to cold chain management in movement from the vaccine. So the nomadic pastoralists are normally served from the designated facilities, border facilities. It is not served from the district or sub-district, but it is served from the designated border health facilities, where the vaccine monitoring also is done by the facility in charge. himself. So that's how the vaccines are normally kept on.
How were they actually kept cold? What was the
There is also, they use ice packs, frozen ice packs.
And they were able to stay cold long enough for the long distances?
Yeah, so every time you use, for example, if I go in the morning for vaccination, they have to use the frozen ice packs. And then in the evening now, those ice packs now are returned to the fridge. They were kept again, frozen. They pick another new one for tomorrow also. So every day they pick another, a frozen one. So that frozen one they maintain, and also they also maintain the shed, so they don't just vaccinate under open air, but they normally use, when they want to vaccinate, they come under a shed.
Yes, yeah. I also really liked the discussion that you had about how you continue the engagement after the campaign for nomadic communities and other vaccine hesitant groups, maybe for religious reasons and things like that. How did you handle those vaccine hesitant individuals? What was it, do you think, that were the methods that you used to have that continued engagement?
Mostly the vaccine hesitancy groups are normally the issues of religious issues, where some have this misconception that they trust in God, and God is their protector, and they don't want to be interfered with their life. So in this, there is also in the polio, during the social mobilization, all the teams were met, their religious leaders were met. So you carry those religious leaders. If, for example, in a village, and an old man just say that his children are healthy, he cannot be immunized because he believes in God. So you just bring him a religious leader for him to intervene. So this religious leader, they normally do social mobilization in the mosque. They do it in the gatherings. So they normally do that to have the misconception removed from the.
It's like the influences. It's like the influences that Shilpi was talking about in India. So it's a very similar methodology.
Yeah, very similar.
Yeah, very similar. Yeah. How were you actually able to reach the more remote communities which are difficult to access?
We normally use motorbike, whereby a team is assigned a motorbike. For example, motorbike travel easier, and they can also try. They don't need big road infrastructure, so they can use the pathway to travel and reach the interior, the border community. So each team, for example, those nomadic communities were assigned a motorbike. The vaccinator and his mobilizer are assigned a motorbike, so they have their motorbike assigned at the village. So each morning they go for that specific community area to vaccinate, and come back in the evening.
Right. So for those of us like myself who are not familiar with the context in Kenya, is there a time frame, do you think, yet for the rollout of a vaccination campaign for COVID?
The rollout we are expecting to start, but so far in the district we have not yet started. We have not yet started.
Not yet started. Well, when you do, you will have hopefully some good lessons learnt from the polio project that you can implement into the COVID vaccination campaign. Thank you again, Mohamed, for your very informative and enlightening presentation. I've actually got, I have a few questions here for in our Q&A time. So I'm just going to ask a question, and I think this is probably a question for Josue, actually, relating to COVID-19. So if the COVID-19 vaccine is only meant to protect from getting seriously ill, but not to protect against getting infected, does this mean that we'll need to still be taking the COVID-19 precautions, such as using masks or practicing physical distancing?
Thank you, Victoria. And yes, by all means, we still need to continue with the physical distancing and masking, using face masks and hand washing and the other measures that we are practicing right now. The main implication for the current vaccine or vaccines that are available right now are to help ease and to help somehow free up hospital capacity, because if we have less people getting seriously ill with COVID, then that means less people will end up in the hospital, and that means the hospitals and the healthcare systems will be able to treat properly those who do become seriously ill with COVID. But we still need to practice the protection measures until there is a vaccine that prevents both disease and infection. And that will probably be a reality, probably, I'm saying, once the actual virus is isolated and a new vaccine is developed based on that virus.
Does the type of vaccine, whether it's RNA, viral vector, and the genetically modified viral vector, does that have any relationship with effectiveness and safety? So, for example, we've heard of reactions. Is there one of these types which is causing the most negative reactions after the vaccination?
Well, reactions are not really. There could be some reactions related to the fact that the vaccine is either based on messenger RNA or using a vectorial virus or different ways of doing it. But most of the reactions are actually caused by the other components of the vaccine. Those vaccines that make those components that make the vaccine stable, so it can be kept for several weeks or months or years in some cases. It can be stored safely and keeping still the vaccine being effective. So those other elements that are added are the ones that are really causing the side effects or the reactions. Now, depending on how the vaccine is developed, those added elements might differ as well, might be different. But that's the explanation on the difference regarding reactions or side effects.
One of your slides had an interesting infographic on it, which showed a group of people in relation to herd immunity, and basically pointed to a couple of people there that weren't able to be immunized for various reasons. So maybe would you be able to explain a little bit more about how the COVID vaccine works with immunocompromised people? Maybe they have HIV, or are they still advised to receive a vaccine or no?
Yes, and at least with some of the vaccines, they have been tested on people who have HIV, and they have been found to be safe, so they can also receive the vaccine. For the others, especially the ones that are not in the emergency use listing by WHO, the fact that they are not recommended for HIV infected people, it doesn't mean it's not safe for them. It just means it has not been tested for them yet, because it's so new. It has been very short time since the vaccines were developed. So the researchers still need to find that out. But there are already a couple of vaccines that have been tested and have been found safe for people carrying HIV.
Can herd immunity be achieved without vaccination?
Well, I should have said that herd immunity is achieved when people are immune, when a high percentage of the population are immune to that agent. And as I explained in my first slide, immunity can be developed, adaptive immunity or active immunity can be developed either through vaccination or through being exposed to the disease. So if you add both groups of people, then you have the total number of people who are supposed to be immune. Now there are some caveats there. Those who have been exposed to the virus, they technically have immunity for 3 to 5 months. They have a good level of antibodies in their blood, and we also need to keep in mind that there are several variants of the novel coronavirus. Right now, the most well-known are 3 or 4, but there are several other variants as well circulating out there. And the fact that one person has been exposed to the virus and has got sick with the virus, it means that that person technically developed immunity against that specific variant that infected them. But it doesn't automatically mean the person has immunity with the other variants as well. Now with the vaccine, some of the vaccines have proved to be effective with more than one variant, but that's still being analyzed as well to see if all the variants are covered. We already have some signs that at least one of the vaccines has limited effectivity against one of the variants. So those caveats will for sure influence herd immunity and the progress in this campaign against the virus.
Yeah, all right. Thank you very much for that, Josue. I have some questions in relation to polio, and Shilpi, I'm going to ask you to answer the next couple of questions. Because this is in relation to India. What kind of people are the influencers in India who help with building the community trust? For example, what positions do they hold in the community? We heard from Mohamed that the religious leaders are quite a pivotal people to include in Kenya. So what about in India?
Yeah, Victoria. So in India also, religious leaders are very important influencers. But in addition to religious leaders, there are other people like barbers, because people go and visit them. So barbers are also influencers. They talk with them when they are relaxed. So they are also a part of influencers. Shopkeepers, ration, the one who keeps ration, because there are ration cards available. People come over and collect food from these people. So while a casual discussion goes on, these are also influencers because they believe in them. Local politicians, and in India there is a Panchayat Raj system. So PRI members or the village head. So these are some of the influencers, list of influencers. So influencers can be a common person in a community who is trusted by the community, and he may not hold any position also, but since if he's elderly also and he's trusted, he is also converted as a influencer.
Very good. It's good to have a wide range. Are you finding very different communication needs with the COVID vaccine versus the polio vaccine, in your opinion?
So the communication need between the polio vaccine and the COVID is almost similar, but the audience or the beneficiaries are a little different. Like for polio vaccination, the challenges were mostly in the area where there was low literacy. But for COVID-19 vaccination, we were having difficulties and challenges even in educated or high literate areas also. The reason is because COVID-19 vaccination was very quickly, there's a very quick turnaround of the COVID-19 vaccination. They were a little hesitant on the trial. Is it completed? Is it not? So these were some of the questions. And to handle this, the government has, what they did was only the health workers were initially given the vaccination on the priority basis. And senior members, senior doctors or senior politicians were or leading the whole program, and they took the vaccination first. It was highly shared in social media so that the trust among the community is built.
Do adults need a polio booster, Shilpi?
Sorry?
Do adults need to have a polio booster shot? One of the questions has been...
No, Victoria. It's only under 5 children we are giving polio drops.
And that takes them through for the rest of their life in terms of immunity. Yeah. So thank you very much for that, Shilpi. I have a couple of questions for Mohamed about Kenya. A question, I know you talked about the cold storage chain, but a question has been asked about whether a specialized vehicle was used to keep the vaccines cold between the central vaccine stores to the regional depots.
Yeah, it's not a specialized, there's no specialized vehicle, but also even we used to support even with our own vehicle to transport vaccine from Nairobi to Mandera, where the project is Mandera. So what they use is only specialized equipment, that deep freezers that they normally use from +2 to +8. So in between that temperature they maintain. So they have that deep freezers where they are going to use to transport the vaccines. Otherwise, there's no special vehicle for vaccine transportation.
Very good. When identifying family members in Kenya who remain behind in a rural or urban centre to engage as mobilisers, have you noticed if certain family members hold a better influence than others? Maybe, I know you talked about religious leaders, but in this example, maybe do men or older women have more trust in their families or communities versus others that may be staying behind?
Staying behind does not mean that they just they don't want to be vaccinated, but sometimes they are nomads. They might be having some humans, some support. Maybe some of their family members were sick, and some of the family members were away, so they cannot shift without their knowledge. So when they remain behind, that means a community elder who is just within that, in a nomadic settlement, in a setup, there is also an elder who is in charge of that settlement, 10 to 15 settlements. So they move it as a group. So they normally have an elder. So this elder is the one that that we are using as a mobilizer now.
How do you work together with static sites, like sites which aren't moving around, to try and promote routine immunisation without the need for a special campaign?
In routine immunizations, the communities have no problem. But the only thing is that the value, for example, completing the immunization is a problem, because the vaccination normally have a stage. There's up to 1.5 years, so they don't normally complete the antigens. So sometimes you can see them, they have taken up to, for example, oral polio up to 3 doses, and then the 4th dose is the measles one. Now, instead of completing at 9 months, taking a 9 months, and then after that 1.5 years, they now left the measles one. So there's also a chance of, because they normally move with animals, and then sometimes because of drought, what's forcing them to move. So in case there's also a volunteer who is assigned at the facility, who normally fast track those who have not completed the vaccination. So he's the one who now do the defaulter tracing for those children who have not completed the vaccines, and he follows up. And once he identifies where the children is now the facility in charge, and they will go and immunize those children with other vaccines also.
Yeah, okay. Thank you very much, Mohamed. We have 1 or 2 minutes left, and I just had some other questions come in. Actually, these are for Josue again. Josue, will the -70-degree storage temperature of one of the available vaccines be a concern, or is there an assurance that has been taken care of, especially in high temperature areas?
Well, when it comes to the logistical challenges it plays, yes, it is a concern, but the degree of concern or the risk will really depend on the capacity of any given country to ensure this -70 degrees Celsius storage. Now, let's keep in mind this is for central storage of the vaccine, because then when it is taken into the field, the very day you will open the vial and administer the vaccine, you don't need that cold temperature in the field. There are different stipulations, but it is something that in real life is causing challenges to some countries. They are having difficulties to achieve to comply with these requirements for the proper storage of these vaccines. So that's why I said that it is somehow good news that there are other options in terms of vaccine availability, other vaccines that are cheaper and also do not have this hard level of requirements for storage.
Okay, thank you very much, Josue. If there are any questions that people have following on from this webinar, you are more than welcome to email our HTLL email address, healthtll@adra.org, and we could answer those in the package that we send out after the webinar. I just want to thank our presenters once again for a very informative, productive webinar. I want to thank also the people who have participated from all around the world and for the many questions that we've had. It's made our webinar an amazing webinar. We look forward to listening to the recording and also sharing the webinar amongst our network and with our colleagues. Thank you once again, everybody. Take care and stay safe. Bye.
Bye.